what we want to do in this final session is really look ahead and think about connection. So if I could have the next slide. In the project, as we've said, we haven't just been working through local field site work. We've also, amongst the project team, been carrying out interviews and attending many of the meetings that have been going on through COVID at regional levels and at global levels. And a huge range of insights have emerged. Some of them are really just about the diversity of what's going on in the preparedness sphere, really catalyzed by COVID. So we're seeing huge differences of scope. So some are talking about preparedness to respond, something that's also called readiness. Others are talking about preparedness to prevent outbreaks occurring in the first place, including looking at spillover and questions of early detection, or the One Health approaches that might be important there. For others, preparedness is actually about protecting populations in the longer term, both through building up health systems or addressing some of the long-term health inequalities that we know were so important in affecting the very diverse impacts of COVID-19, and thinking about how health systems can be made resilient. And then preparedness for others came through as about mitigating not just the health, but also the social and economic impacts of the disease itself and of the response. Also, in the global and regional discussions about preparedness, we see emphasis on different measures. So some are talking about pharmaceuticals and diagnostics and vaccines, and how platforms can be built so that they can be produced more quickly and delivered more effectively into the future. Others are talking about supporting the supply chains to overcome some of those problems of inequity of supply. Others are talking about data, or about tools of all kinds for surveillance and indeed for building and measuring community capacities and resilience. But what we've been struck by through those global and regional interviews is some key issues which perhaps are not as central as they might be. They are there, people are talking about them, but they're not at the heart of the global and regional conversations about pandemic preparedness. And I think the insights that we've gathered from other parts of the project, and indeed from our discussions at these higher levels, is a suggestion that maybe they need to come more centrally to the heart of preparedness thinking. So there are four really that emerge. One is about the longer term systems investments that attend not just to health, but also to wider precarities and vulnerabilities, and equip the world and countries to be able to mitigate those and respond to them. The second is about institutions and authority, making sure that preparation and preparedness encompasses the ability to have those informal as well as formal capacities in place, and for those to be flexible and adaptive, fostering relations of trust, but also institutional abilities and capabilities to be able to deal with uncertainties in the heat of an outbreak. And that requires some preparation in advance. Then there's knowledge, which we've been talking about a lot, but actually the room for social and contextual knowledge, as well as that which comes from biomedical and epidemiological areas. But really importantly, and this came out in the last session, that preparedness needs to encompass the deliberations, the dialogues across different kinds of expertise, so that when an outbreak hits, those dialogues can continue in a more seamless way. And finally, we need to have, I think, more explicit attention to power, to politics of all kinds, formal and informal, and the ways that those affect and need to be addressed during preparedness so that they're there for response. And all of these themes are ones where actually the intersection of the local, the national and the global are relevant, and where we need perhaps to think harder about, to pick up on some of the phrases from the last session, building bridges building connections, overcoming what I think our earlier sessions have made very clear are so often disjunctures and contradictions between the languages and the styles of reasoning of the global and the regional, and those which are happening perhaps closer to the local realities of people's lives. So this final panel wants then really to think about connections, and we've got a super panel that I'll introduce in a moment, but we pose to them 3 questions which overlap a little bit. How might global and regional efforts interconnect more effectively with what we've been illustrating and concerned with around preparedness from below? What kinds of local capacities, global local relations, what kinds of mechanisms might help to strengthen this kind of more inclusive systems preparedness that can really attend to local realities in all their variety? And then finally, how might the kinds of concerns that we've been raising through this project and which have emerged through the webinar become a more central part of these current and future global conversations about pandemic preparedness? So to share with us their thoughts on each of these questions, we first of all got Dr. Chikwe Ihekweazu, who occupies a really key role in this area at the moment. He's Assistant Director General for Surveillance and Health Emergency Intelligence Systems at the WHO, but he's also now leading the WHO's own hub for pandemic and epidemic intelligence. We'll then turn to Dr. Sylvie Briand, also in a key position here as Director of Epidemic and Pandemic Preparedness and Prevention at the World Health Organization. And then to 2 people who kind of bridge the worlds of policy and academia. So Professor David Heymann, who's both a Professor of Infectious Disease Epidemiology at LSHTM and the head of Chatham House's Centre for Global Health Security. And finally, we'll turn to Professor Susan Erikson, who's a Professor of Health Science at Simon Fraser University. So again, each of you has been asked to share thoughts for perhaps not more than 5 minutes so that we have time for some more open discussion at the end. But over to you, Chikwe, to start us off.
Thanks, Melissa, and thanks for the invite. And I listened into the last, I think, 20 minutes. Really interesting conversations going on, not only here, but around the world on these particular topics. But I guess to start with saying that while we wouldn't say there's been any exemplary performance on the outbreak from the global south, as we call it these days, we obviously didn't expect that to happen anyway. But what we did expect to happen was for those exemplar responses to happen from other parts of the world, from which it didn't actually happen. So what this situation has enabled us in a way is to have an honest conversation with each other. Because in a way, if this pandemic had played out the way most of us expected it to play out, we wouldn't be having many of these conversations, because the obvious conclusions that we tend to draw would have been drawn. We would have said, yes, the bad performers all the time perform badly, the great guys performed well, and that's just the way the world is. The reason we're having these conversations is that things didn't quite pan out that way. So it's a very important moment to recognize. And as we have these conversations on structures, on preparedness, what it has brought out is this need, this, in a way, obvious need to collaborate. But true collaboration only happens when there's mutual benefit for each other. So there's no real partnership that happens when there's only one side benefiting from the partnership, even when there's an overload of resource on one side. Because true partnership and true collaboration only happens when we fundamentally believe that there's benefit in that collaboration, in that partnership for both sides. And in a way, if that's one lesson we've learned from this pandemic, that is obvious to many of us on this call, but maybe not obvious to everyone else, is that our existence is really dependent on finding a model for this collaboration to happen, and really doing it not out of the normal donor instinct or how much of our GDP do we allocate to aid every year. That's an important conversation, but it's a different one. This conversation really is about how much do we invest in enabling a collaboration that we need in order for our own survival and our own existence. And once we can frame the conversation in that way, I think we have at least begun a journey into answering the hard questions. And when I speak about collaboration, at least in this space that I'm leading on at the moment on behalf of the organization, is really to think across our organization, across all the disease areas that we work on, each of which is very important in its own, for its own reasons, right? Is how do we enable that sharing of resource, sharing of expertise, sharing of knowledge, of platforms, recognizing that the next pandemic can come from any of these pathogens. And if we don't work across these diseases that we work on, we continue to lose an opportunity because of getting the best value out of the work that we do. And it's not just across our disease areas, it's across professions, across the sectors. You know, we've all agreed that the One Health concept, it's important. But having worked myself at the country level for 5 years at the leadership level, I know how hard it is to actually bring the actors working on zoonotic infections, on the animal-human interface, on behavioral science. I know how hard it is to bring them on the table to work collaboratively in a single country, but we can't stop trying. Collaboration across countries. Very often when we talk about collaboration, our mind immediately goes to countries for one reason or the other that we think are not minded because of political, social reasons to collaborate with each other. But at the moment, there are very few examples of good collaboration happening between countries that are neighborly, friendly, and have absolutely no political or social reason not to collaborate with each other. And just to make it easier, I'll talk about the countries neighboring Nigeria, where I worked for 5 years. There's very little collaboration happening on meningitis, for instance, between Niger and Nigeria, that is separated by an artificial border that has a common set of risk factors for a whole set of diseases. But because we haven't focused sufficiently in the incentives and opportunities of collaborating, we're not doing so. So at the moment, it's not really about the countries that refuse for one reason or the other. It's that at the moment, we haven't even focused on building the opportunities for collaboration between neighboring countries. So having said all of that, as a situation we face, what are we doing about it? Right now, we're having very interesting conversations within the organization and our member states on a new concept called collaborative surveillance that really intends to push the boundaries around these areas, recognizing that they're not easy boundaries to push because we have socialized ourselves for decades to think around these borders, whether they're geographical, whether they're disease specific, whether they're in our different professions. But we want to push these borders and see whether we can win over hearts and minds to come together and start thinking about the challenges that we face and how we can address them collectively while not giving up on our specific interests around specific diseases or specific spaces. And that really is the work that we're leading at the moment. The new hub for pandemic and epidemic intelligence here in Berlin is built on this collaborative model. It's a hub based in Berlin, but it's really a hub for the world. And we really hope to bring in colleagues, not only epidemiologists, but really social scientists, colleagues working on the animal-human interface, colleagues working across all the professions, and not only in public health, but in academia, in philanthropy, and see whether we can build a model, a physical model of collaboration by actually bringing colleagues together to think about these problems, think about how to address them in the long run, and also support our response work in the organization so that the emergencies program in our own organization is both a client and an owner of the hub. So we are part of the emergencies program. So the outputs of our work will be directly translated into improving our own response capabilities, but we will not be drawn into the acute response, so that the organization also has a model through which we can build for the future and support our member states. And Melissa, I'll conclude on one thought.
Yes.
It's become increasingly clear that the focus of activities has to be at the country and very often at the subnational level, because that's really where the authority to respond lies. And by the time it gets to the stage of WHO organizing a response and declaring it, grading it an incident and declaring it a fake, we have lost a critical opportunity to respond. So all the work that we're going to do, most of it, that clarity of thought on where the intervention is most needed is becoming increasingly more manifest. And I think in the next months and years ahead, I hope you will see a lot more focus on how we as an organization are supporting our member states to lead on the response, rather than seeing WHO in front of any response, defining surveillance systems, defining activities. Our role is to support countries to do the work they need to do, provide them the structures to collaborate, and hopefully through that, our work will be a lot more focused on supporting them. So let me pause here, but of course, open to taking the conversation in any direction you and the colleagues would like. Thank you.
Thank you so much. And that's actually very exciting to hear about collaborative models. And I think the challenge, clearly, as you've said, will be to make sure that the power and the knowledge in those collaborations flow from the bottom up as well as the top down, and actually really work across levels as well as across the expertises and countries and other kinds of boundaries that you've talked about. So very, very positive to hear that the hub is moving in that direction. So turning now to Sylvie, from your perspective in WHO, where do you sit on these important challenges for the future?
Thanks a lot, Melissa and others, for inviting me first, and really congratulations to the previous speakers. It was a really very interesting presentation, and I think it will help enormously also to shape the future so that we are a little bit better prepared. On your first question, Melissa, I think how to increase the connections. I think it's also very important to recognize the key characteristic of epidemics and pandemics, because then we can, when we understand what it is, then we can also get better prepared. And the key characteristic, in my opinion, is first the fear. There is a lot of fear. And as you know, when you are fearful, you don't make necessarily the best decision. You may want also to have an authoritative approach and a very disciplined, drived approach. And so the fear is an essential component of those crises. The uncertainty has been also alluded to by other speakers, so which means that the uncertainty and the fact that it's not one size fits all, because different countries will be affected at different moments with differential impact. So there's a lot of uncertainty, but also a dynamic situation. And the third element, I think, is the risk that it's for any crisis, but an epidemic as a health crisis, let's say, has an impact. It's the threat to the cohesiveness of the society. And so, as Chikwe said, maybe if you are lucky, it will, I mean, when people fear, the same threat, maybe they can be more collaborative and more united. But usually what I have noticed in most of the crises, it's the contrary that happens, is that really, and especially for epidemics, because it's transmitted from people to people, it undermines the cohesiveness of society. So having in mind those three factors, I think it also already gives us some tips on how we need to get better prepared, because we need to anticipate those characteristics and therefore get ready for them. On your second question about local capacities. So here I have 4 comments I would like to share with you all. The first one, I think, is we have seen in the various presentations that there are different paradigms for the response. One paradigm is the command and control. And this is the paradigm that is very much linked to, I would say, military approach. And it's very hierarchical and top-down. And another paradigm is human-centric. And it's the paradigm we are discussing today, where the community is at the center. But Julian was saying that we need a balance between different paradigms, but I do think that currently the human-centric paradigm is really a minority. And if we really want to shift paradigm, we really need to do also a lot of advocacy, a lot of communication around it, because currently I don't think it has penetrated really the political level that it needs to penetrate. And so we still have a lot to do on this issue. My second comment about the local capacities we need to build is about the methodology, and especially for field researchers, as what alluded to by one of the speakers, because the pandemic is a very dynamic event. For research in the field, we need also to have a lot of flexibility in the methodology. And very often academic research is not flexible. You define your methodology before, and then you apply it conscientiously throughout the research, and you don't change it. But I think it's also, if we talk about research in emergency, I think we need to also change paradigm there and have specific methods for social science in emergency that will not undermine the quality of the results, but will take into account this need for flexibility because of the uncertainty of the event, and also because of the fear that is around. So obviously certain techniques that works in normal time will not work anymore in a time of emergency. The third point is really we need to take into account the previous crises that have affected the population. For instance, and the issue of Ebola was, for me, I've been through most of the crises of this century, so I can give my own experience. But when we were responding to the plague outbreak in Madagascar, many of the responders had done the Ebola outbreak, and so they were just copy and paste the intervention from Ebola. But plague is a respiratory pathogen, and so I mean, there was nothing to do as for Ebola. I mean, the intervention are different, the approach is different. And so it was very hard also to make responder adapt their approach to another disease. And so I'm not talking about COVID because others have talked about it. And the fourth point, I think, on local capacities, many speakers have highlighted that the problem with all the public health and social measures is that they will have probably a good impact on health, on the health situation by reducing transmission and so on. But they do have adverse effect, if I may call them so, on society, economies, and so on. Unfortunately, those adverse effects are rarely measured, and also they impact much more vulnerable groups. I mean, those groups who are vulnerable before the crisis will be even more vulnerable to the adverse effect of PHSM. So we have now a group in my department working on those public health and social measures. And I would like really much to make the connection, because we are talking about connection between your groups and these groups, because they are really developing also methodologies to assess those negative impacts on the society. And your last question is, how can we make those concerns more prominent in the global dialogue or debate? I think first, we need to recognize that when we talk about human-centered approach, it has obviously some political implication. And for instance, a colleague from South America was talking about what is happening in his country, but I remember that I was working in Peru many years ago, and the government launched an initiative called Vaso de Leche, which was to provide a glass of milk to children. And they relied on the community, on groups of women to deliver this intervention. But after some years, I mean, those women became very powerful politically. And the government just stopped the initiative because of this political implication. So I think we shouldn't be naive. Whatever we do will have political implication. And I think it's better to know it before rather than discovering it when the intervention is done. My second point on how we can shape this more at global level is also if we promote the two-way dialogue and the co-development of intervention, which is really something I value very much, I think we will have also to change the vocabulary. And someone was mentioning the surveillance becomes social listening. We at WHO, for example, we are promoting infodemic management. And if you look at our publication, infodemic management includes social listening, communicating risks, promoting resilience of communities, and community engagement and empowerment. So it's not the infodemic. Many people are talking about infodemic as rumors, but we have really broadened this approach. It's much more than rumors, and it encompasses a number of interventions that I think are very much aligned with what you think as well. The third point on this issue of how we can advance for the future is really also.
Can this be your last point, just in view of time? Yeah.
Okay. Great. So I think it's very important to increase communities' literacy, health literacy, science literacy, and social media literacy. And finally, we talk a lot about community engagement, but I think we should talk a lot about community empowerment. Because community can do much more if we give them gloves, if we give them what they need also to protect themselves. And very often it's just, I would say, just communication, blah, blah, posters and so on. But I mean, if you want people to wash their hands, they need water, they need soap, they need everything. So we need to associate methods. And my final point, because I think it's very important, about the history and previous crises. Most of the countries and communities in the world have been through COVID-19. And as you have seen, there is now a mistrust in vaccine everywhere. And so I think we need to take this into account in our preparedness. We are not starting the preparedness for the next pandemic with a population that believe in vaccine. On the contrary, we are starting now the preparedness with people who don't trust vaccine. And so we really need to have a very active engagement on vaccine therapeutics and other things, and trust in the health system, because unfortunately, this crisis has reduced our capital of trust in many places. Thank you. Sorry if I was long.
No, that was great. Those were all such fantastic points, and really speak to this idea about the importance and yet the challenges of really shifting power and languages and all that follows. So wonderful. I will turn now straight on to David Heymann.
Thank you, Melissa. And it's really been a pleasure to listen and hear all the comments coming from countries, because that's what we do such a poor job at in many, many situations. But I'd like to start by just paraphrasing and summarizing what I believe Chikwe said, and he can correct me as we go along if I'm wrong. But what I believe I heard Chikwe say is that what we really need to do is get the balance right between global, national, regional, and local levels. We need to get that balance right in some way. And at the same time, we need to do a better job of listening to what is needed by countries and what they want and feel they need. And this latter point really was driven home to me recently when I participated as a facilitator in a course on vaccines. It was for Africa. It was given out of Ghana, but it was Africa-wide with public health leaders. And it's a course that I participate in each year with the National University of Singapore and the London School of Hygiene and Tropical Medicine. This course teaches application of vaccines, and at the end of the course, there was a poll. And the poll was, what is the priority vaccine for use in your countries? And this was actually last November. And at that point, in fact, almost all participants said, malaria vaccine is our priority. And when asked why COVID-19 vaccines weren't a priority, there were several responses. One was a graph that had been done in Senegal, which showed the antibody level of COVID-19 was already above 90% in most areas in Senegal. And the second was a comment that I won't forget, which was from one who said, you know, he said, our populations perceive vaccination for COVID-19 as a means of the North protecting themselves by vaccinating us. And so I think we really have to be careful as to what we say globally. And this was right at the time when WHO continued that we need to get vaccines throughout the world to 70% of the population. So it was really driven home to me at that time that we really need to listen better. And today I've been able to listen quite a bit and really have understood much of what's going on in countries. But to come back to how do we ensure that we get the balance right, I think we've already made great progress, really. The International Health Regulations in 1969 were an attempt to stop disease at borders by such measures as vaccination if you were coming from a country with yellow fever. By 2005 or 2003, it was understood that this really wasn't the way to go. And the revision in 2005 did two things. Number one, it placed the requirement on countries to develop the capacity to detect and respond where and when diseases are occurring in order to save lives in their own countries, but even more importantly, globally, to prevent the international spread of these infections. And at the same time, it provided a safety net where countries were to work together if indeed there was an outbreak, so that they could help the countries stop the outbreaks. So the IHR made a step forward, but unfortunately, after 2005, we saw what happened was that many governments didn't engage in providing or in developing these capacities. And at the same time, the donor community did not engage in providing at least matching funds to countries to do the job of developing their core capacities. And so we're left now with a void in this. And I think good evidence of what happened with the IHR 2005 is that countries each year were required to provide to WHO a report of their progress in capacity development. If you look at the map of countries that didn't report in the period after 2005, you'll see that by 2011, there were 3 countries in West Africa that were not reporting, and they were Sierra Leone, Liberia, and Guinea, the countries in which the outbreak took off dramatically. Yet countries that had reported their capacities were interested enough to do that, were Nigeria, Senegal, and Mali. And in those countries, in fact, they were able to stop outbreaks when there were importations. So I think there is some importance in what the WHO does in these reports, and I hope that countries will continue to develop their capacities. We have a possibility to make that occur even more with the treaty which is being negotiated by WHO on preparedness. But in reading through it recently, I noticed that there's really a lack of one word throughout that, and that is prevention. This is all about being prepared to respond and not going further back, as Chikwe said, to that One Health approach of preventing the spillovers and other activities from beginning. So hopefully that will be rectified in this treaty, but the treaty could really help us get the balance right. It could make sure that at the global level, we're not creating mechanisms to respond to outbreaks. We're creating mechanisms to help countries establish their core capacities and have access to the goods that they need. At the regional and national levels, it's engagement making sure that countries are engaged and they will, in fact, not only develop the preparedness and the prevention activities that they have, but be willing to share their skills with others. And finally, at the national level, at the subnational level, and at the local level, we need to do a better job, all of us, in listening and in responding to the needs as identified. The decolonization approach that is so important right now. So thanks, Melissa, and back to you.
Yeah. Wonderful, David. Thank you so much. And again, a lot of key points, and actually the prospect of this global treaty that the WHO is pushing forwards really, I think, sets a very high bar and an important moment to get all of this right. And I think taking that broader look at what preparedness means, not just preparedness to respond, but preparedness to protect populations and to prevent future outbreaks, surely needs to be a vital part of that. So thank you for those thoughts. So finally, I'm going to turn to Susan, who's played a wonderful role as a member of the advisory group for this project. And at this final point, please do share with us your thoughts on the future.
Thanks so much, Melissa. Thank you to the entire pandemic preparedness team for their significant, highly significant social science work. But no surprise, I start my comments today with a critique. As everyone in the research team already knows, I'm not a fan of the characterization implicit in the title of our webinar, the term "from below." I know that the research team's intention is to upend that ordering. So even as I celebrate and will certainly cite the research team's impressively prolific scholarly accomplishments, I continue to be discomforted by the subject position of "from below," because of the work that the term does not, sorry, it's very early here in Vancouver, so I'm going to start that sentence again. So even as I celebrate and will cite the research team's impressively prolific scholarly accomplishments, I continue to be discomforted by the subject position of "from below" because of the work that the term does to render and to reinforce the familiar orderings of things and people in global health, an ordering that I see as harmful, retro, and self-defeating to us all. So I will use my comment time to bring to the fore what I see as a problem of recognition, or as Franz Fanon and Glenn Kohlhart have put it, the politics of recognition. And to illustrate my point, I want to share a conversation I recently had with a former CEO of a large Canadian company. We happened to meet on a forest trail not far from my home, and on that day, among the tall trees with our dogs running circles around us, he began talking, lamenting really, about the decline of liberal democracy around the world. He waxed philosophical about the loss of social norms of true freedom, equality, and democracy, and how he just couldn't see how European and North American countries would recover from the decline. And as we continued talking, I realized that his lament was very much grounded in the limits of who he saw as capable of leadership. He suffered from a failure of imagination about who would lead in the coming years and where good ideas would come from. He expected the same set of old white dudes to come to the rescue, and he could not see hope or help or good ideas coming from what I'll call here the elsewheres. He had a recognition problem. He had lived comfortably in a world of asymmetrical recognition for the whole of his life, and he could not envision a reciprocity of recognition with the elsewheres. He could not and would not see alternatives to the way things had always been done, and he is not alone. Global health and pandemic preparedness as fields of power suffer from a similar politics of non-recognition. People within both fields continue to look to old guards of public health for answers to pandemic and pandemic preparedness. The Global Health Security Index, for example, out of the Johns Hopkins Center for Health Security in Baltimore, Maryland, in the USA, continues to rank the United States #1, and we're talking in 2022, even though the United States has the highest COVID death rate among the world's wealthiest countries. Even though Sierra Leone, and this is a fact, even though in early 2020, Sierra Leone was testing for COVID-19 and had testing protocols in place weeks before the United States did. In another research project I'm involved in on digital technology use in several countries, including Sierra Leone, we also see a politics of non-recognition. Even though high functionality, technological innovation and capacity exists at the local level, the research reveals that there were specific directives from the US Centers for Disease Control, the CDC, and the ministry not to use them and to favor instead technology that the donors were familiar with. So I'm not talking about adaptation here. The research shows that the technological innovation is originating in Sierra Leone. And if you doubt this, then dare I say it, you may be part of the problems of recognition. The pandemic preparedness project today demonstrates tenfold why knowledge, experience, and leadership from the elsewheres begs recognition. And so to the challenges of pandemic preparedness that have been deftly identified today, I add one more. We must also work to upend the usual global health politics of asymmetrical recognition. And that is a seriously heavy lift, one that will take generations likely and will require changing people's minds about where good, smart preparedness is and where it's likely to come from in the future. The speakers today have given us a truckload of evidence to work with, and I wholeheartedly thank them for their research. And thank you for your kind attention.
Okay. Wonderful. Susan, thank you. And thank you for bringing power and politics squarely back to our concerns. And indeed raising these problems of language, the way we label things and places. We've struggled throughout this project, which was set up in terms of levels, but yet levels we constantly want to overturn and play with and cross. You've suggested the elsewheres as an alternative to below. But is that actually any better? I think we're all struggling with a language which is not up to the task of generating what I think we all see as a much more connected, fluid, mutually listening, mutually appreciative, bridged world for thinking about preparedness and the power relations that it involves. So we've just got a few minutes for questions back to this panel. Please put others in the Q&A if you'd like to, but we've got one here from Dan Vink, particularly to Chikwe, regarding the framing of partnerships between, as it were, the more conventional global and regional agencies and communities. And the suggestion is that partnerships always need to be based on trust. How can those trust relations be built? And is informality enough? Do we actually need partnership arrangements in which communities can hold more authoritative and powerful institutions to account, to respond to their needs, to respond to their priorities? So that's a challenging one for you. I'd be interested in your thoughts there.
Thanks, Melissa. It is challenging, and I would say the reality is somewhere in between, right? We need both. We need both bottom-up building process of communication, listening, engaging, learning, but we also need a few structures, and really it depends on what level we're speaking about and how action is happening. So a lot of the discussions today on the social sciences and how to build trusting relationships, which is what enables ultimately for response to happen, and discussions around Ebola and outbreaks like that, and what leads to vaccine uptake, or what leads to the adherence to safe burial practices. All of that only happens when the healthcare provider, the citizen, and your public health infrastructure is working together, because a setup where you have a health clinic that you don't rely on to provide your basic maternal health services to mothers delivering their babies is not going to somehow become trusted when they talk about coming to offer vaccines or Ebola-related services or whatever else we now think is important as public health providers. So this is not, there are no quick fixes here. We have to really work very hard from now and not wait for the next pandemic, and start engaging and working and building across both our everyday clinical service provision to our prevention services and our response, public health response services, and really think together. And it's not easy because we've all been socialized to believe that the answer lies in the authorities, and the higher the authority, the better the answers, and WHO being naturally the highest placed authority in public health has all the answers. So even for a lot of us within the organization, there's a re-socialization necessary in order to then listen effectively and use it really to adapt the way we work, rather than just listen and go on working the way we've always worked. So you're right, I don't have all the answers, but I do know that in the context of the work that we're doing, there are no, I think there are much fewer people that think we do have the answers, and at least that is a starting point that will force us to listen, and hopefully through listening, working together, engaging, if we do that in the right way, we will come up collectively with a better approach to the problems that we face.
Okay, excellent. Thank you so much. I'm just wondering, there's a hand up from Alfred Jamiru. I don't know if that's a legacy hand, as they say, or whether there's a live question you'd like to ask.
Well, no, it's not a live question. This is Alfred Jamiru.
Great.
First of all, I just wanted to caution all of us, and I usually say this to colleagues, that we should not be too hard on ourselves, because when we look at pandemics and where we are in today's world, we have come a long way. Mm-hmm. And we have come a long way, and we have made a lot of progress. And it is settings like these, discussions like these that have been put together that will help us move forward. Mm-hmm. So having said that, I just want to congratulate everybody that works in the pandemic. You know, because it's not easy usually, as we know, all of these viruses or diseases come with their own, size, etc., and what have you, and it's a whole different approach. What I wanted to say really is that as we speak about preparedness, we must have to really link preparedness to various segments of what we are involved in. For example, when we talk about preparedness, technology preparedness, because when I was working for example, for coronavirus here in Sierra Leone, we have tablets that were supplied to us. But then our field officers were not trained enough to be able to use the tablets. Now, when we talk about vaccination preparedness, at the end of the day,
Hello, you've just, Alfred, I think you've just muted yourself. Okay.
Right, so I was talking about, and I'm going to go faster because we're rounding up. I was talking about preparedness have to go with all aspects of our work. Preparedness in technology. For example, in Sierra Leone, we have tablets and laptops, and field officers were not able to use that. So it took a while to be able to train them. And I think that in preparedness, we have to train before we get to that point. With vaccination, one of the things that I found out with vaccination is the denial was so much because there was so much dark fake news in social media, which was being filtered into the communities. And I was confronted that, this vaccination, is going to kill us. So I just asked a simple question. Ask us, if they want to kill you, you have a cell phone, not so? Yeah, we have a cell phone. If they want to kill you, don't you think that they should have killed you through that cell phone? And so the messaging, you have to be quick on your feet when you are in the communities, because sometimes what we are actually trained, or we train our staff for, when they get into.
Okay. Alfred, I think that's great, and we're short of time, so we might.
Well, I know. Thank you very much.
Wind up at that point. Right. Wonderful. Yeah. Right. So, just very quickly, I wondered if there's anybody else from who's spoken in previous sessions, or from our project team, or indeed from other people who've been involved on the advisory group for the project, who's got a final quick question or comment they'd like to make. Okay. Okay. In that case, or perhaps So Sylvie, then yes, to come back to you. Give us a last word on this before we close.
No, it's not really the last word, but I was just thinking that we often talk about communities, but communities are mostly seen in low-income countries.
Yeah.
While I think what would be really nice is to have a reciprocal anthropology and have researchers from the South coming to our countries in the North to look at the issue of community engagement. How can we also engage communities during crisis? I think this would be very enriching, in my opinion, to get some advice from those researchers. Thank you.
Great. Well, I think that's a fantastic point to finish on, because it really drives home both the universality and yet endless diversity of the challenges we're dealing with, and actually that really important decolonial move, which doesn't just shift power, it actually reverses power. And it brings the elsewheres to the center and turns the centers into elsewheres. It does not just the bottom up, as it instead of the top down, it connects them in different ways. We've had a lot of, I think, important ideas that have come out of the whole webinar, but particularly of this last session. Upending power, wider notions of preparedness, which are not just about preparedness to respond to disease, balances between global, national, local, between disease priorities and economic and social priorities, building bridges. One of the interviews we did with our global level talked about building bridges, and if you build a suspension bridge, you have to build it from both ends at the same time and meet it in the middle. And at that middle point, we've heard a lot about the importance of listening, the importance of mutual understanding, and the importance of building capacities both ways round, so that everybody can listen better to each other and understand better what each other are saying. So I think this has been an incredibly rich discussion. And I'd like to thank everybody who's been part of this session in particular. And we'll now hand over to Hayley to make some final remarks.
So thank you very much. And first of all, I just wanted to show a final slide with some of the published outputs from our project, that some of the papers that you've heard mentioned, and in the same vein to say that we've recorded this webinar, and it will be available early next week, also through IDS. So if we go to the final slide, you will see the link there where you'll be able to find the recording where it says visit and the IDS site from pandemic preparedness, and obviously the slides and the recordings will be available there. Also to say that we are currently preparing a special issue on preparedness for the Journal of Biosocial Science, and that'll also come out next year. And finally, if I can just add my thanks to Melissa's, first of all, to all our project researchers for the work they've done in preparing the videos and presenting findings and chairing the sessions. And thank you so much also to our wonderful discussants from both sessions for coming and offering brilliant remarks and being so engaged. And then also to the panelists in the final session who've really presented fascinating thoughts. And thank you also to Susan for really bringing us right back to the question of shifting power, which was the title of the webinar. And finally, thank you to the audience for all your questions and your engagement. I'm sorry we haven't managed to answer all of them. We would follow up with people individually if that's possible, but we really appreciated your comments and in the chat and in the Q&A. So thank you very much.